Most clinicians find insomnia frustrating to evaluate and treat. But in clinical practice, most cases come down to just a few things. And once you know what to look for, the evaluation becomes surprisingly straightforward. So in this video, I'm going to walk you through the workflow that I use in my clinic to evaluate insomnia. And I'm going to show you 3 things that dramatically improve insomnia evaluations. I'm Dr. Nishi Bhopal. I'm a psychiatrist and sleep medicine physician. On this channel, I teach clinicians practical ways to understand and treat sleep problems in everyday practice. You can also earn CME credits for this video. You can get those through the Learner Plus link, which is in the description below. All right, so one reason that insomnia cases can feel so frustrating to manage is that most clinicians receive very little formal training in sleep medicine. Often you get just a few hours across medical school and residency or your clinical training program. So if insomnia cases sometimes feel confusing, it's not a reflection of your clinical skills. It is a gap in your training. The goal isn't to turn your clinic into a sleep lab, but what helps most is simply having a clear clinical framework for evaluating insomnia. And clinicians who become comfortable evaluating sleep often notice this. They start getting better outcomes for their patients. Their confidence starts to grow, and you become the clinician that colleagues refer their insomnia patients to because your patients get better. So that can be incredibly rewarding in practice. How do you actually uncover what is driving your patient's insomnia in your clinic? So let me show you a case that illustrates how this plays out. I had a patient in her early 40s who was referred to me for insomnia by her psychiatrist. She had already tried several different sleeping pills without success, and by the time she was referred to me, she was taking zolpidem or Ambien regularly, but it was not working as well anymore. So when we started the evaluation, I asked a question that I now ask almost every insomnia patient, which is, tell me about your sleep environment. It turned out she was living in a small studio apartment in San Francisco, so she was sleeping in her closet, which was the only separate room. It was unventilated. The room was hot and stuffy at night, and she could not breathe. So we made one simple change. I had her move her bed closer to the window, out of the closet, so the room was more breathable, and her sleep improved almost immediately. What struck me about this case is that she had seen several clinicians already, tried different medications, but no one had asked her about the bedroom environment itself. And that wasn't the whole story, so as we continued the evaluation, another issue started to become clear. She had subtle symptoms suggestive of obstructive sleep apnea, and this had never been evaluated. So we got that tested, and it turned out she did have sleep apnea and is now getting that treated. We also applied some behavioral principles from CBT-I, which is cognitive behavioral therapy for insomnia, particularly reducing the amount of time she was spending awake in bed. Over time, with all of these changes, her sleep improved significantly. She was able to taper off the zolpidem, and she began sleeping even better than before. One thing that I've noticed after evaluating hundreds of insomnia patients is that insomnia rarely just has one cause or just one treatment. It is usually a pattern across multiple different factors. Once you start identifying those different factors, treatment becomes much more targeted and effective. And often the interventions themselves are surprisingly simple once you understand what is going on. So if you are a clinician who would like a structured clinical framework for evaluating and treating sleep issues, I've put together a short free clinical course for healthcare practitioners where I walk you through this process step by step. You can get that at intrabalance.com/doctors, and you can also access it through the link underneath this video. So after evaluating enough insomnia patients, I started noticing that the contributing factors almost always fall into 4 main categories. And I sometimes use the acronym FEEM to remember them. These are food, environment, emotional factors, and medical conditions. Food includes things like caffeine, alcohol, reflux from late meals, or sometimes nutritional issues like low ferritin, less than 100, which can contribute to restless sleep. The environment includes the bedroom temperature, light exposure, noise, and consistency of the sleep schedule. Sleep hygiene falls into this category too. Emotional factors include anxiety, rumination, trauma, and the conditioned hyperarousal that can develop around sleep. And medical causes include various things, including conditions like sleep apnea, restless leg syndrome, circadian rhythm disorders, and other medical and sleep disorders. When you start going through these categories systematically, the underlying contributing factors often become very clear. A clue I often listen for is when patients say they sleep better when they're on vacation. And that tells you something important, which is that their relationship with their bed at home is a key contributing factor. Patients will also give you clues in the language that they use. For example, listen out for patients who say things like, "I wake up with panic at night." They may be describing sleep apnea. A patient who says, "I've tried everything and nothing works," often has a lot of frustration and hyperarousal around sleep. And someone who says things like, "I've always been a bad sleeper," may have developed a strong identity around having insomnia itself. These small phrases can be quite revealing. When I explain sleep, particularly sleep drive or sleep pressure to patients, I often use an analogy. I'll say, think of sleep drive like hunger. If you have a snack right before dinner, you're not going to feel as hungry when it's time to eat. Sleep works in a similar way. If you're spending too much time in bed, your brain doesn't build up enough sleep drive or sleep hunger. Sometimes we actually need less time in bed so that the brain can rebuild that natural drive to sleep. Next time you have a patient with sleep issues, you can use that analogy. So I'm all about making your clinical work even easier because we're so busy in clinic. One of the things you can do to make your insomnia evaluations easier and more streamlined is to use some standardized questionnaires. For example, the Epworth Sleepiness Scale, the Insomnia Severity Index, the GAD-7, and PHQ-9. I'm also a psychiatrist, so I also include the Mood Disorder Questionnaire as well sometimes. I will also have patients complete a sleep history form before the visit so that we can use our appointment time more efficiently to do the thorough evaluation. The American Academy of Sleep Medicine has a free sleep history template PDF and a free PDF sleep diary that work really well. But another part of the evaluation that is just as valuable, if not more, is not a form or a questionnaire, because sometimes the most important perpetuating factor in insomnia isn't related to sleep at all. It's the patient's relationship with sleep. So this is where a simple patient-centered interviewing model called FIFE can be incredibly helpful. FIFE stands for feelings, functioning, and expectations. It is a patient-centered interviewing framework that is commonly taught in Canada, although I haven't seen it emphasized as much here in the US in clinical training. But what's interesting is how much insight these 4 questions can reveal in just a few minutes. For example, feelings. How are you feeling about your sleep problem? Ideas. What do you think is causing it? Functioning. How is it affecting your daily life? Expectations. What are you hoping we can accomplish? When you ask these questions, patients often pause and will say something like, "Oh, no one's ever asked me that before." And what comes out can be so informative. You might discover that the patient believes they have to get 8 hours of perfect sleep every night, or that they're worried insomnia means they'll develop dementia or another serious health problem, or that they're hoping that the one medication or one supplement will finally fix everything. These beliefs and expectations can reinforce that vicious cycle of insomnia, and they often don't come up unless you specifically ask. The patient that I'd mentioned earlier, questions like these helped reveal just how frustrated she had become with her sleep and how much pressure she was putting on herself to sleep well every night. And that kind of pressure can keep the nervous system activated at the exact time it needs to wind down. So in addition to screening for sleep disorders and environmental factors, understanding the patient's relationship with sleep is often one of the most important parts of your evaluation. Once you start evaluating insomnia in this way, you will start to see this. Instead of insomnia cases feeling mysterious or intangible, you begin to see patterns. After evaluating enough insomnia patients, these patterns become very predictable. In that patient's case, once we addressed the environmental issues, treated the sleep apnea, reduced the amount of time she was spending in bed awake, her sleep system gradually stabilized, it recalibrated. And what has stayed with me about that patient's case is that the solution did not require an advanced intervention or finding the right medication. The key was simply identifying the contributing factors that had been missed. In the next video, we'll talk about how to treat insomnia in clinical practice, including some behavioral principles that you can start using right away with your patients, even if you don't have access to a CBT-I referral right now. I'm curious to hear from you. What phrase do you hear the most from insomnia patients in your clinic? Tell me in the comments below. And if this was a helpful video, share it with a colleague, because most clinicians receive very little training in sleep medicine. I'll see you in the next video.